Welcome to Spectacle on Television Nigeria. I am your host, Daniel Atai. Over the years, in almost the administrations of this fourth democratic dispensation, Nigerian medical doctors, medical students, and institutions have had cause to go on strike. Also, the facilities of our health institutions are said to be in a state of comatose or millipede growth of recent. Oftentimes, we were overwhelmed with diseases or disease outbreaks, especially the wake of the COVID-19 pandemic. It is in this light that we wish to set the agenda straight, looking into medicine and medical practice in Nigeria. Welcome to Spectacle. I am Daniel Atai. I have in the studio of Television Nigerian the president of the Nigerian Medical Association, but before I properly introduce him, let's take a commercial break, and when we come back, I will do so. Please stay tuned. Welcome back. On Spectacle today is Professor Innocent Uja, the President of the Nigerian Medical Association and the Vice Chancellor of the Federal University of Health Sciences, Otupo, Benue State. Sir, you are welcome to Spectacle.
Thank you very much.
It's a pleasure having you here, sir.
I'm delighted to be here.
All right. Now, before you begin the analysis, Prof, or analyzing the topic on discussion, let's take a background reportage of medicine and medical practice in Nigeria with a preamble I could lay my hands on. Please do enjoy the clip. Over the past few years, there have been many anecdotal reports about the challenges that doctors and by extension other health workers face working in Nigeria. Most Nigerians are familiar with the lack of equipment, the heavy workload, the absence of opportunities for development, and poor infrastructure that can be seen in the health sector. Less widely appreciated are some of the specific challenges that individual doctors face in training and achieving their career goals. From spending 7 years in medical school, often extended by the disruptive frequent strikes that we have decried in previous posts, to the difficulty in finding places of complete the compulsory one-year housemanship program within 2 years of graduation. The lot of the new Nigerian doctor is not an easy one. Then after NYSC, that is the National Youth Service Corps, the compulsory 1 year of national service mandated for every Nigerian graduate, there is the challenge of finding a job, often driven by the paradox that jobs for doctors in a country that has not met recommended World Health Organization density of doctors, nurses, and midwives can be hard to find. Part of this is probably because of the concentration of health workers in urban areas. But whatever the explanation, the effect is that we often have unemployed doctors looking for work. Even setting up on your own clinic is a challenge because of the cost of equipment, rent, and other expenses, unless you choose to cut corners, which some do. For many doctors, the pinnacle of their career is completing a specialist training program or residency to qualify as a specialist. Getting into one of these programs is again another mountain for the contemporary Nigerian doctor to climb. There is a course of the qualifying primary examinations and study materials to grapple with, as well as a high failure rate in these examinations. If the young doctors manages to cross these hurdles, there is the challenge of finding a place in an accredited hospital to complete the program again. And again, these programs are challenging to complete on schedule because of the aforementioned frequent strikes, the lack of quality educational materials, the high examination failure rates, and the challenge of studying for the examinations while also trying to make ends meet financially. These programs often take up to 5 or more years to complete. At the end of the journey, as a qualified specialist, there is the challenge of finding a consultant job. If this hurdle is again cleared, there are then the challenges of working in an under-resourced health facility where patients can often not afford treatment, even in the public facilities, compounded by poor work environment and poor management. It is little surprise that there are more and more anecdotal reports of doctors choosing to leave Nigeria to work elsewhere. Some of the questions that come to mind reading this article are: how can the issue of frequent strikes in the health and education sectors be addressed? How can the process of appointment to house officer programs be improved? Do we need a centralized system that is transparent and works better at matching candidates to opportunities? Is there a role for a tech solution here? How can we incentivize health workers to make working in the rural areas and poorly resourced parts of the country more attractive? The midwife service and showpiece mechanism schemes achieved some success in this area, but appear to both have been discontinued. Are there lessons to be learned from these programs? How can the process of applying to specialist training be improved? Can there be innovative ways of financing the initial course? Can there be tech solutions to make the educational materials more easily available and cheaper? Are the high failure rates in the specialist training programs justified? Are the colleges conducting audits to understand why the failure rates are so high, and are they doing anything to address this? Are we doing enough in working out how many doctors or specialists each health facility need and aligning these to the training places available? Can the process of appointment of consultants and all health workers be more transparent and better aligned to the needs of each facility and the outcomes expected? How can we improve the working condition for our health workers to improve retention? These are weighty questions, but ones that we need to address urgently if we are to buoy the morale of health workers and retain them in the system. Welcome back. And that has been the background reportage on medicine and medical practice in Nigeria. And thank God we have the NMA president in the studio in the person of Professor Innocent Oja, who will be doing justice to the topic on discussion. The program is an audience participatory one. You can reach us via the numbers that are displayed on your screen. And also, if you are opportune to use your Zoom, you can hook up to our Zoom page when the time is up. So they are displayed on the screen for you to follow. Now, Prof, this is Nigeria, your country, and today you are the chairman and the president of the Nigerian Medical Association. Congratulations once again.
Thank you very much.
Thank you.
I'm delighted and I'm grateful that you show solidarity and gratitude to my election.
Thank you
as
very
the
much.
president of Nigeria Medical Association.
That's good. Thank you. All of us in TVN, we wish to partner with your association, and we also wish to help to set agenda for the Nigerian Medical Association.
Thank you very much. And we are delighted because the health of Nigerians is a main preoccupation.
Okay, good. Now, talking about the health of the state of our health facility in the country, how would you, especially now in the advent of the COVID-19 pandemic, how would you say we are ready, or are we okay? Are we doing perfectly okay to handle the situations of outbreaks, incessant outbreaks, especially the one that we have now?
Well, I think that the first thing we should look at is public health in Nigeria.
Okay.
And public health deals largely with preventive medicine.
Okay.
I.e., how do we prevent common disease conditions?
Yeah.
Issues of cholera, issues of Lassa fever, and what we think like the childhood vaccine preventable diseases in childhood.
Yeah.
These are basic things that every country would want to have.
Okay.
And then, of course, clean, potable drinking water.
Okay.
These are basic things that we should have.
Okay.
Whether these things are at its optimum, it's clearly obvious that we have not arrived at that stage yet.
Okay.
We have cholera because of open defecation, because of bad water. And in fact, sometimes there's no water, no potable drinking water. We have been having Lassa fever that has been on for years, something that we believe can be prevented. Unfortunately, it's a yearly thing. We know it's now residence endemic in Nigeria.
The Lassa fever.
Lassa fever, but it has its own ups, particularly during the dry season. Between September to February, you find that the incidence becomes quite high. So obviously we have a lot to do. We have a long way to go to achieve this, and it borders largely on illiteracy and poverty. When you say poverty, people always think that poverty is financial poverty, or poverty of ideas. And largely many Nigerians have little or no knowledge of how to prevent common diseases. What we call simple hygiene. For instance, we're talking about COVID-19. Unfortunately, the global health emergency that we have. The basic things to do is prevention. How do we do that? By washing our hands regularly with soap, and then using sanitizer. And now we have to use face masks, and then social distancing. But compliance is very poor. So by and large, whether we are ready, we've seen that to the extent that we have the facilities, to the extent of manpower, to the extent of commitment, by and large, I believe that we can do more than what we are doing. Because we know that the global pandemic has brought every country to its knees. Europe, America, we thought they were the greatest. But we found now that we are at the same level.
We are at the same level?
We are at the same level as far as COVID-19 is concerned. The number of cases, the number of deaths. I mean, so because those are the measure of success or failure. And the large number of people.
That is amazing.
Yes, in terms of this COVID-19, the pandemic, we thought that such things will not happen, in such places. And even if they do, they can easily be contained. You recall that when we had Ebola in 2014 in Nigeria, Ebola is usually restricted to underdevelopment. But COVID is, in fact, has no friend. So every part of the world is involved. When we had Ebola, Nigeria did very well in Ebola. I was the co-chair of Ebola diseases. And the reality is that when it happened, Nigeria contained Ebola very quickly. The level of preparedness was such that, one, because Ebola came through Lagos, and Lagos, there's no doubt that Lagos is the most prepared of all the states in this country. And Lagos was able to intervene very quickly There was leadership in terms of the governor giving his own leadership. Even the president then also give political leadership to it. And then there was central coordination, effective coordination by the Honorable Minister of Health then, Professor Onyebuchi, and then the commitment of the health workers. So it was contained, and it was thought that it was easy. However, when COVID-19 came, we thought we were ready, but you and I can see now that we're not ready. You know, our level of preparedness and response clearly, you know, will actually require a lot of, in fact, it's gaping. The truth is that COVID-19 has actually shown Nigeria as having a very, very weak health system.
Okay.
That is the truth. Yes, we have manpower, but manpower can never be enough.
Good.
We have to train and retrain. Facilities, obviously the facilities are overstretched. Even then, the equipment are not there. You can see that when we started, I think in the PCR machines that we had in Nigeria, at the time, that was by the 27th of February, when the first case of coronavirus was reported in Nigeria. We didn't have up to 5 PCR machines. But today, there's some improvement. We have about 33, I think, or more. That's an improvement.
Yeah, and when you say PCR
yes,
machine, for the layman,
this is a machine that is used to detect, you know, COVID-19, the virus.
Okay.
Yes, it is a very sophisticated machine that is used to detect. That's a laboratory machine that is used to detect, you know, COVID-19, and that is the best that you can have. So when when COVID-19 started, was first reported, we had only about 5, but today we have about 33, and that is not just enough. There are some states that still don't have the PCR machine, the lab for it, because it's biosafety level 3 machine. I mean, a laboratory that should be able to take, because of the precautions, because you have to prevent infections, you know, to those who are providing the laboratory services, the pathologists, the medical laboratory scientists, and even cleaners, you know, could get affected, could be affected if or infected if precautions, what we call universal precautions, are not taken. That is infection control, infection prevention and control.
Yes.
If care is not taken, many people can be infected. And as you know, the reports we're getting from the field show that the doctors, nurses, medical laboratory scientists, even drivers are infected, you know, as a result of providing service. That means we need further training, we need equipment, we need consumables. Like when we talk about PPE, that's the personal protective equipment that you use to ensure that you don't get infected in the service of
taking care of other
patients. Yeah. You know, so it becomes very difficult. So by and large, yes, the government, as far as I know, the political leadership under the president has done well. They have approved some fund, and we have a PTF that is working round the clock, and we have coordination. But the coordination, in my opinion, needs to be better effected.
But is that still the problem of the president or the problem of the...
Well, you see, leadership is leadership. The issue is that we need the coordination, and I'm coming to that because there's discordance. When the central coordinators say this should be this, the governors are saying something different. And I believe that the command and control, because this is a national emergency, and I believe that the president should call some of the governors to order. Because the coordinating mechanism is such that there should be central control from the PTF and
that's the presidential task force.
Yes, the task force on COVID-19. We have a national coordinator, as you know, and they need to, all they do is to monitor, evaluate, and give directive, accredit labs that are qualified to do the tests. But some governors are even saying that there's no COVID in their places, in their own. If you don't test, how would you know?
Exactly.
And the issue is that the incubation period is about 14 days.
Yeah.
Right? That's on the average. And people die. You saw what happened in Kano when they said there was nothing like COVID. But verbal autopsy shows that many of them that died of COVID-19, coronavirus disease. So what we need to do is to be focused, to be more serious, to be more committed, in this. I know that in some places they said they don't have COVID-19. That, in fact, one ridiculous one, when somebody was asking me that if they say there is COVID-19, why is it that bodies are not littered all over the place? That statement is very callous. Because why should somebody die before you believe that there is a disease? If it's a relation or friend or brother or wife or husband that dies, it will be very painful. But to others, it doesn't matter. And I think we shouldn't look at that, shouldn't do that. The other thing that I thought should have happened is for the National Orientation Agency to take its job properly, because our people need to be informed. Okay. We have we have a large illiterate community, and if it requires using the local languages, the National Orientation Agency should do that. We have to deploy the town criers in the communities, the wards in the local governments, to help them to pass the message. Communication is very important, and effective communication is very important. But the truth of the matter is that Nigerians are very pessimistic. Okay. When you are doing something, somebody will say, well, it's because of money, because money on its own doesn't mean anything. Exactly. Right? Exactly. So I think that we should be more serious, in containment of COVID-19. And we should learn lessons. Okay. And the way we can learn lessons is to document. Okay. Because anything you do without evidence will come to naught. And the research component, in my opinion, is missing. I believe that we should be more serious in the research component. By now, we have getting to 500 deaths. By now, we should be able to disaggregate, who are the people that are affected, that die. Of these, how many of them have comorbidities? Like the age, you talk about age, is a factor, it's a risk factor. You talk about diabetes, hypertension, HIV, hepatitis, liver disease, kidney diseases. We should be able to disaggregate it by now, and publish it. Okay. Because those are the things. And publish it. And publish it. Good. Because by now we should be able to know the direction we are going. And we monitor and evaluate. We monitor what we are doing. How best can we do it? Are we doing well? If we are not doing well, how better can we do it? Because that is the essence of research. Yes. You should be able to drive the response. And I believe that the federal government of Nigeria and the states should have research teams. Their own is to monitor and evaluate. And also that will bring out evidence. Okay. Who is involved, where is it, where are they, how are they, what are the factors. And in that case, because it's a new disease, so nobody has the answer to it. Whether it's in Europe and America, nobody has the answer. But do we have in the country, under your association now, or let me say generally, do we have specialists, trained specialists, and incentivized specialists in the country? Well, let me tell you that Nigeria is not lacking in specialists. Okay. We have specialists in infectious diseases. That's their own. Okay. We have specialists in public health. Okay. We have epidemiologists. Okay. But they need to be brought together. They need to be motivated. Yes, that's why I say incentivized. Yes, but you see that these are the problems that we face. We need to approach things squarely. Okay. Devoid of politics. Exactly. Let science drive the process. Thank you. It's only science that can drive this process. You need a political way to help galvanize, but political process, politics should take the back seat and allow science to take the front seat,
Okay.
and then they can prepare,
Okay.
and then move, and then achieve our objectives.
And when you talk about science taking, politics taking the back seat,
Yes.
you know so well that politics is the one to provide the funding.
That's right.
Yes.
The fund, you see, that's what we talk about, the political will.
Yes.
Once there's political commitment, they provide a fund, they also monitor the fund, because it's not enough to provide fund. You should be able to monitor the disbursement and the utilization,
Okay.
of the fund. And that is the element of transparency and due process and accountability.
Good.
So that is what they should do. But the issue of saying that we don't have COVID-19 in our place, how would you know?
Or
if
the
there's
issue of
no
saying
test?
we don't have specialists.
We don't have specialists. You can import specialists. Even during the Ebola, we had people who came from Europe and America to help us at the time.
Okay.
Now you can move specialists from one state to the other. Their experiences. Unfortunately, we lost the value of, or the gains of Ebola, because if we had documented this properly,
Okay.
our level of preparedness and response
Yes.
to COVID-19 probably would have been better. For instance, I can say on authority, because I was the co-chair of the treatment research group on Ebola, that about 250 Nigerians were trained from here and exported to Liberia, to Sierra Leone, and to Guinea to go and help them contain Ebola.
And yet, some Nigerians are saying we don't have medical facilities in the country.
Yes, but
we don't have nothing.
No, we have the brain.
We have the brain.
But probably the facilities are not there.
So
we train, and when they got there, they were able to help contain Ebola in Liberia, and Sierra Leone, and Guinea, in the West African countries. So I'm not sure, but I hope that these people are now being put to use for the containment, because they had experience.
Yes.
They knew many things that had gone wrong, or what they did to help contain the Ebola. So all we needed to do was to inject this group of people to the response.
So how do we improve? How do we improve specialists? And engaging them. How do we improve them right now in the country?
How do you improve them? Already they are being produced. Let me just say too that in the 60s and early 70s, most specialists, in fact, all specialists were being trained abroad.
Okay.
And it was actually draining the foreign exchange.
Okay.
Until the National Postgraduate Medical College was established to train specialists in the various fields. And then the West African Postgraduate Medical College was also established. It was then in the 70s, getting to the late 70s, that Nigeria started producing their own consultants. Otherwise, we needed to go to Britain or the US.
After medical
school. To get specialized.
Okay.
And that one, even in that, some people go there and they don't come back. Two, the foreign exchange.
Okay, they go.
Yes,
they don't return.
They don't return.
And it's the country that sent them there.
Yes, the country that spends the money. So we're conserving a lot of foreign exchange, which many people may not appreciate. What it takes to train a specialist abroad is so much. In fact, you don't use it in Nigeria. You don't use up to 1/4 of the cost of training a specialist in Europe or America. So we've done well in that regard. Unfortunately, there are limited training facilities. And this is where some of the states must wake up.
Okay.
Because at the moment, it is the federal government institutions, most of them, that are training specialists. Again, you have to forgive many of these states. They don't have the capacity. I know that a state like Lagos, a state like Delta, what other state? Rivers, Kano is doing well, but that is federal institution actually. It's not still federal institution, but the state institutions.
Okay.
For instance, even house job, there are so many states that don't have hospitals good enough to train house officers. So we depend largely on these federal institutions, federal health institutions, the teaching hospitals, and the federal medical centers. And they are not just enough. There are a few other states that have facilities and manpower to train house officers and residents. And there's not enough.
There is not enough. Now,
That is a problem on ground.
Yes, it is.
And could you say that the issue why most specialists fly abroad, or people that have finished medicine, their first level medicine, fly abroad, could you say is a factor of the equipment, lack of equipment?
There are many factors. The operating environment is very harsh.
What do you mean by that?
I'm talking of the facilities. If you are in a hospital, you don't get the best that you need to practice.
Okay.
You have the brain, you've been trained, but you'll be surprised. Not now, but in my younger days, we used to operate. Okay. And when you're operating, they take light. What do? You use torchlight. That's the worst thing that can happen. You're operating, a patient is under anesthesia, and then next thing is that they take light. There's no light. And the backup generator may not be functional.
Jesus.
And then all you need to do is to see how you can salvage this patient with using torchlight. And I'm not kidding. I'm not sure whether it still exists, but it's not impossible because the supply, the energy supply in Nigeria has not improved significantly. So you find that you are frustrated. You know, to operate on one patient, the preparation for it takes hours. Fortunately, I was practicing in the University of Jos University Teaching Hospital. Okay. But being able to reduce what we call decision delivery interval for cesarean sections. Okay. Sometimes you would stay for 3-4 hours to operate on emergency because either the theater is only one, other operations are going on, or when you want to operate, there's no light, or when you are ready, probably the autoclave is not working. So these are some of the frustrating things. But if you go to Europe and America, if you take a decision that this patient needs to be operated upon, within 10 minutes, they are ready. Everybody is on standby. They'll be ready. The theater is ready for you. So those frustrations are gone. But then, also, even the remuneration of doctors and other health workers, if you compare, other countries, it's something to feel very bad about. You could say that we're not the same with them, but it's also true that you need to motivate your staff to work well, to put in the maximum that they need. And in medicine, you need maximum concentration.
Thank you very much.
You need maximum concentration. And one of the ways to do that is, for instance, if you're practicing in an environment that you don't need to bother. Okay, for instance, as a doctor, if you have a child in school and you are operating, you may have to stop the operation or finish quickly and go and pick your child from the school. Or you have to wait. Now, in a normal environment, in an environment where social services are provided, you will get all you need to do to probably pay for buses. I know, and the bus will drop your child at the door, and then he or she goes in. But we don't have such facilities, so the environment is not conducive. I must say.
Facility is a factor.
Yeah,
and
equipment. Equipment. Yes.
No. Even as we are talking about the third level, I think we're talking about third level facilities.
Yes.
At the
tertiary institutions. Yes.
What about the secondary and the primary health levels? What could we say about that? And what incentive could drive specialists to be at the rural areas? Because like in my local government, it is capital zero. And we have human beings there. We have even sick patients, especially the aged. Sometimes we are helpless. Even the one primary health care that the government will put there, no facility, no medicine. So how do we, turn back the hands of time in this situation, sir?
Well, it's to prioritize. It is very sad when you talk about primary healthcare facilities. I think for the
tertiary level.
No, even at that level, the National Primary Healthcare Development Agency.
Yes.
Is doing its best, but it cannot do all those. It cannot do everything.
Who is doing his best?
The National Primary Healthcare Development Agency.
Okay,
that's job for all primary health facilities.
Okay.
The good thing is that we now have what we call the National Health Act that provides basic health care provision fund of at least 1% of consolidated revenue. Right, and even then, this is not being released because that is meant for the primary healthcare facilities. And if it becomes operational and it operationalizes very well, then some level of care at the primary healthcare level will be much better. Now, apart from the Southwest that I felt I know, you don't have a doctor in any of the primary healthcare facilities. There's none.
Yes. So even doctors, even if you post doctors to the primary healthcare, they say they want to stay in the urban cities.
No, it's not that they want to. It's just that they have to. The reason is very clear. You post a doctor to a primary healthcare facility in rural area. There are no schools for the children. There's no water. There's no light. All you need to do, the governments need to do, is to provide these services, and people can move. The roads are very bad.
So the factor of basic
infrastructure is very important. It is very, very important. It's not that they don't want to, but you see, there is no distance anymore. I now stay in my village and watch the DSTV. I watch this TV programs from my village.
Yes.
Previously, it was impossible.
It's true.
But now we can do that. You communicate with the world. So if the roads are made, are improved upon, if facilities can be improved, consumables are made available, schools are functional, that the children of these doctors and nurses and other health workers can go to. I mean, people in fact, the chaotic nature of the towns will even make it possible, more enduring to go and stay in the village because there's no distance anymore.
I will not bug you much, but we'll have a lot of questions here for you, but time is not our friend. And I think after the short break, we'll discuss on process of why the examination rate for people trying to go to specialize themselves in different fields are so difficult to pass for the medical doctors, those that have passed their first levels. Why is it difficult, and why is it that we don't seem to have much people in this part of the world trying to study medicine? We'll be back shortly after this short break to meet with our prof in the studio, Professor Innocent Uja, the president of the Nigerian Medical Association, and who also doubles as the VC of the Federal University of Health Sciences, Otupo, in the studio of Television Nigerian to discuss medicine and medical practices in the country. Please stay with us.
A broadcast network committed to serving you the very best in online and offline television programming. Situated in the serene environment of Guzape, Abuja FCT, TVN, as it is fondly called, caters to a wide variety of audience via carefully orchestrated mind-blowing programs in the areas of fashion, business, politics, entertainment, religion, movies, food and health, culture and lifestyle, events around the globe, sports and foreign news. Whatever your inclination, we've got you completely covered with programs like Issues of the Moment, The Patriot, Daybreak Nigeria, Matter Africa, TVN Business Time, Healthy Living, From the Cradle, Stay Inspired, Entertainment Gist, Movie Hour, Hits Paradise, among others. All designed to keep you thoroughly informed, entertained, at the edge of your seats and yearning for more. A tour around our domain will reveal a highly dedicated staff force and a state-of-the-art facility and equipment for high-definition quality broadcast, making our station your #1 choice in advertising your business and propagating your ideas. We are currently on NightComSat doing our test transmission for takeoff in the nearest future. Television Nigerian is located in Nigeria at Television Nigerian House, Guzape Hilltop Mansion, beside Guzape White House, Guzape Abuja FCT, and in the United Kingdom at 45 Ancient House, 48 Aerodrome Road, Beaufort Park, Colindale, London. For inquiries,
welcome back. We have few minutes to call it a day here on Spectacle. We are discussing medicine and medical practices in Nigeria, and we have in the studio the NMA chairman, Professor Innocent Abuja. Now, before we went on breaks, I said I want to ask you this question. If we are doing enough in working out how many doctors or specialists each health facility needs to align itself with, both at the rural area, at the secondary level, and the tertiary level.
Well, thank you very much. Let me just correct this. Okay. I'm not the chairman, I'm the president.
Oh, the president, I'm sorry. I'm sorry.
Correct that.
Yes, thank you, sir. You are the president.
Yes, that's right. So,
my error.
No, it's okay.
Thank you, sir.
When you say enough, it's obvious that we cannot get enough.
Okay.
We don't have manpower development plans that we follow. It's very sad, and everything is chaotic. Otherwise, we should know how many doctors or nurses that should be available in a facility.
Yes.
And then you see the gaps, and how you fill the gaps. The mobility of labor, and with the immigration of many staff, not just doctors, even nurses, move out of this country because of dissatisfied work environment. So it is difficult to say this is what we need, but it's also good to plan it.
Yes.
And say what, so that we can then look at the gaps. But a situation where in the local government areas, I mean, it's unfortunate that in some zones, in some parts of this country, a whole central district doesn't have a consultant.
You don't mean it?
I mean, zone C and zone A, I think. Apart from Makurdi, let's look at Benue as an example.
Yes.
Apart from Makurdi, if you go to zone C, or what we call the Benue South Central District,
yes,
there is no single consultant.
You don't
no specialist, there's none. If you go to Boko, which is zone A, there is no single consultant.
And what factor led to that?
Well, the government is not employing. And if you employ, what facilities they have?
So we are
for instance, in the whole of in zone C, apart from the general hospital in Otukpo, the rest, well, they are called general hospitals, but do they actually match up to the facilities, that the status of a general hospital,
of a secondary
health facility?
Okay.
This is the secondary health facility.
Yes.
So largely you find that most states depend on the federal health institutions. For instance, in Benue, apart from the BSU that I just come up, the Federal Medical Center was the one providing tertiary health services.
Okay.
Apart from that, there's none. You go to some states, the only thing you can see is the Federal Medical Center or the teaching hospital. So the dependence on the federal institutions is quite high. And I believe that the states should do more. Do more by training and equipping the health facilities.
Now, Sasa, there's something I want you to clear us. The teaching hospital, and is it categorized under the secondary health sector or the tertiary?
No, the teaching hospitals are tertiary. That's the highest you can go.
Okay.
And also the Federal Medical Center.
Okay.
They are tertiary institutions.
Okay.
Now the general hospitals, cottage hospitals, are the secondary level. And then of course you have the primary health care facilities where you treat basic illnesses and also immunizing children. Yeah, yes, at that level. Those are the things they do. And then referral.
Okay.
As soon as they cannot, they see a case that they cannot treat, they must refer to the secondary center.
All right.
And where they cannot, they refer to the
teaching
hospital. Yeah, the teaching hospitals or the Federal Medical Center, as the case may be. Unfortunately, our referral mechanism, our referral process is not in place. A situation where patients are kept in a facility even when they know that they don't have the capacity to treat. It's a commonplace, and it's not good. And also even the private sector.
Right.
Once you know that your capacity is not there, either in knowledge or in equipment, you refer.
All right, thank you very much, Professor Innocent Uja, for coming on Spectacle program on television Nigeria. I believe that when we have the cause to call you again, because we shall, you will make yourself available for your country.
By His grace, yes, I will, because we need to educate, we need to inform the public, because a large number of Nigerians have very little knowledge about health, even their own health.
It's true.
Yes, they prefer to take a bottle of beer than go to check for medical care, checking their blood sugar.
It's true.
Yes.
And when you come on this program again, I would like to talk about vaccines, the various vaccines we have in this country, because we have a lot of terminal diseases that is common apart from COVID-19,
That's right.
and how we could prevent our children from
dying of vaccine-preventable diseases.
Yes,
that's right.
Thank you very much for coming, sir.
Thank you.
We appreciate it.
It's all right.
And this is where Spectacle will stop today on television Nigerian. I have been Daniel Atai. Do well to follow us on our social media platform. And of course, in the studio has been Professor Innocent Uja, the president of the Nigerian Medical Association, doing justice to the topic on discussion that we have just finished, the part 1, which is medicine and medical practices in Nigeria. Please, another day, we'll hook up with you. Thanks for watching. Welcome to Spectacle on Television Nigeria. I am your host, Daniel Atai.